Community Health Matters was made possible by a grant from the Tri-City Healthcare District Board of Directors Community Healthcare Alliance Committee.
Welcome to this edition of KOCT Community Health Matters. I'm Vicki Beck, and today I'm talking to staff from the Vista Community Clinic. For more than 4 decades, VCC has been well known in North San Diego County for high-quality, affordable health care in primary care, women's health, pediatrics, and dental health. Each year, more than 58,000 patients receive care in 5 state-of-the-art facilities in Oceanside and Vista. In addition to medical care, VCC improves community health through health education and screenings, which allow North County residents to take charge of their health and well-being. My first guest today will talk about diabetes and hypertension, 2 chronic conditions. To begin, I'd like to welcome Dr. Donald Ong, who is a primary care physician, and Victoria Harris, a clinical programs manager. Welcome to both of you.
Thank you.
Dr. Ong, I'll start with you. Let's talk about hypertension first. How many people are actually affected by hypertension at some point in their life?
Well, first of all, hypertension is a major risk factor. It's
and we're talking about blood pressure.
Yes.
High blood pressure.
Hypertension is a major risk. Hypertension is a major cause of morbidity and mortality in this country. When we speak of high blood pressure, 2 numbers come to mind: systolic and diastolic. The systolic is the upper number of the blood pressure reading, and diastolic is a lower number in the blood pressure reading. If your systolic blood pressure is greater than 160, your chance of having a stroke goes up 400%.
So this is why we have to be careful about hypertension. Correct. Because of the risk of stroke, which can lead to,
well, many problems. Mm-hmm. And let's say, for instance, if your diastolic blood pressure is greater than 95, your chance of developing coronary artery disease also goes up 200%. And if you have high blood pressure, blood pressure greater than 160 over 95, your chance of developing congestive heart failure goes up 400%.
So who's at greatest risk for developing high blood pressure?
Yeah, the ones who are at greatest risk, I usually differentiate those as those that we can control and those risk factors that we can't control. Mm-hmm. The risk factors that we can't control are usually genetics. If you are African American or male under the age of 50, or postmenopausal women, or if you have a brother or sister who have high blood pressure. Now, there are things that we can control, and those are obesity, lack of exercise, smoking, stress, salt in the diet, diabetes, cholesterol, caffeine, alcohol intake, as well as patients with low calcium and potassium.
So we're talking about lifestyle issues in addition to other disease.
Correct.
So diabetes is a cofactor in raising?
Oh yes, it is an independent risk factor for diabetes as well.
Okay.
Hypertension as well.
So tell us a little bit more about how people can control their hypertension. It does sound like it's critical to control because of the association with so many other problems, and death and disease being the biggest problems. What is it you recommend for patients? How do you get them to control their blood pressure?
Well, the most important thing is behavioral modification. Mm-hmm. Like I said earlier, there's nothing we can do about if it's genetics. However, if it's not genetics, then we usually talk to patients about obesity and overweight. We advise them to lose weight. We advise them to exercise about 30 minutes per day for most days of the week. We advise them to stop smoking if they smoke. We advise them to reduce their stress through exercise, through yoga, tai chi, whatever mechanisms that they use to reduce their stress. We advise them to reduce their salt intake. About 2,300 milligrams per day, teaspoons per day, which is 2,300 milligrams per day, which is 1 teaspoon per day. Or in high-risk patients with coronary artery disease, or if you're African American, we advise them to have no more than 1,500 milligrams of salt per day.
So is salt the same as sodium when you're looking at the label?
Yes.
On a food product? Okay. What about medication? At what point do you recommend medication for patients?
Well, if the blood pressure medication is, the purpose of blood pressure medication is to control the blood pressure to reduce the risks, to reduce the harmful effects of the blood pressure on the body. If the patient, as I mentioned earlier, if they have symptoms, if they have risk factors that we can't control, medications become the primary means of controlling their blood pressure. But if the patient has high blood pressure as well as risk factors that we can control, then medications becomes an adjunctive therapy in behavioral modifications.
Sure. And Victoria, you work with patients in doing screenings or health education. Tell us about that.
Absolutely. All of our patients with chronic conditions, hypertension and diabetes alike, are offered health education services when they come in for a clinical appointment. So what we have is a position called a care coordinator. So when the patient comes in, they will meet with a care coordinator who will provide that health education, like Dr. Ong was saying about diet and exercise, weight loss. They'll give them all of that information while they're there at the visit.
And does the patient come back so that you can check to see if they're actually keeping and maintaining those?
The care coordinator will then follow up with them over the phone, give them a call a week later, let them know, how are you doing? Are you checking, your blood pressure at home? Are you monitoring what's going on? Are you looking at your diet to see if you're making those changes that we suggested when you were in the clinic?
So you do this for both hypertension patients and diabetes patients.
Absolutely.
So let's switch gears here and talk just a moment about diabetes. What are some of the complications if a patient is not following those lifestyle habits and doing everything that you recommend?
I think, the biggest thing that we focus on with our diabetic patients, one of the complications is vision problems. And so we strongly suggest that they visit our optometrist once a year and make sure they're checking that their vision is still working well. There are other things that, high blood pressure, again, like we said, they're cofactors. So if your diabetes is out of control, your blood pressure may also be high. They can have issues with nerve damage, with kidney damage, vascular problems, getting circulation to their feet and their hands sometimes, skin issues.
What are the early signs of diabetes specifically?
I think Dr. Ong could probably talk to that a little bit more, early signs of diabetes. You want to touch on that?
Well, typically when patients have early signs of diabetes, they usually don't know it until they have problems with polyuria, meaning they urinate a lot, or they feel they have thirst, they have a lot of thirst, and they actually are not gaining weight.
And this is for type 2 diabetes?
Yes.
And what's the difference between type 1 and type 2, just briefly?
Well, type 1 briefly is usually they occurred very young, young age, and they usually require insulin for them to metabolize their sugar.
And type 2 is what older people?
Older people, and usually in this days and age, it's usually associated with obesity.
Okay. Victoria, could you comment a little bit about the resources and support services that Vista Community Clinic is offering patients and how they access those? Do you have to be a patient there, or can you be someone from the community and actually access that?
Absolutely. So for our patients specifically, we have the in-clinic kind of education during the visit. We also have specialized nurses for diabetes who will see patients on a walk-in basis. They can just walk in and sit with the nurse and get that specific in-depth education on diet, exercise, how to take their medications, that kind of thing. We also offer group medical visits for diabetic patients where they will get a 45-minute lesson from the nutritionist and a food demonstration to kind of show them how to eat healthy, and they'll get some more time with the nurse as well. And those are for our patients specifically. For the community, what we do is support groups. So we really notice within our group medical visit that this peer-to-peer support and motivation works really well.
And do you work with those support groups?
Absolutely, absolutely. Right now, we had a pilot with the American Diabetes Association where we had a support group once a week, and it was very well attended. So now VCC has extended that internally. We have a once-a-month support group where actually one of our providers, Dr. Ong has come and spoken before, will speak to the patients about different complications with diabetes, motivate them to work with each other on those lifestyle changes, walk together, exercise together, talk to each other about whether or not you're checking your blood sugar appropriately.
And are you getting people coming back to continue with the support group? Okay.
Yes, and that's really important because, they make friends and then they have someone together with them, partnering with them in this, it's a lifestyle.
It sounds like a wonderful program. Thank you both, Dr. Ong and Victoria Harris, for being with us to talk about hypertension and diabetes so that patients at Vista Community Clinic can take charge of their own health. After the break, Dr. Loretta Stenzel will talk about HIV and hepatitis C.
It takes less than 1 minute to find out if you may have prediabetes. you can do it here. But you probably won't. You're busy. Kids, work, show coming back in 48 seconds. So let's do this now. Hold up one finger if you're a man, women, 0. 3 more fingers if you're over 60, 2 over 50, 1 over 40. If you're not sure, keep in mind you're sitting on a couch right now, so 1 more finger if you're not very active. 1 finger if yes, 0 if no. 1 yes, 0 no. Next, find the body type that looks most like you and hold up that many fingers while I look around awkwardly. And that's it. If you're holding up 5 fingers or more, you probably have prediabetes. Sorry to be so blunt, but hey, you're busy. Just go to the site.
Welcome back. In this segment, we're talking to staff from Vista Community Clinic about HIV and hepatitis C. My guest is Dr. Loretta Stenzel, who is a family medicine physician at VCC and a member of the HIV care team. Welcome, Dr. Stenzel.
Thank you.
We know that VCC has been in the forefront for many years with HIV treatment in patients. Can you tell us how that has evolved over the course of time and what we're seeing since the early 1980s when it was first diagnosed?
The treatment has gotten much better. It's easier to take, less complicated, less side effects. It's accessible to people. Anybody with HIV who wants treatment should be able to get it. It's generally very, very effective.
What about people who are at risk for HIV? Has that changed since the early 80s and 90s?
The risk factors are still the same: unprotected sex with an infected person, intravenous drug use, contaminated blood products, not sterile tattoos. So those have pretty much stayed the same. There is more options for people who might be at risk. So they're having sex with a new partner, or they want to establish a relationship with someone who has HIV, maybe on treatment, and they're kind of wondering, well, how can I do that safely? So there is medication now that's proved that you can take on an ongoing basis if you are not infected, that will significantly reduce the risk that you might get it if you have some sort of sexual contact with someone who has HIV.
So is this the PrEP
So this
approach?
is PrEP, is the kind of the nickname for it. It's called pre-exposure prophylaxis. It's actually fairly simple to do. You get a few blood tests to make sure your kidneys are good and a couple other things are going on. Make sure you don't already have HIV. It's a pill a day. Most of the insurances are covering it. If you don't have insurance, there are ways to facilitate having access to it. And you take a pill a day and it's just pretty simple. Then you need to follow up with the doctor that's prescribing it every 3 months just to make sure things are still going well.
So tell us about the care and support that's offered by the clinic. The clinic must be offering this type of PrEP.
So yes, so quite a few of our physicians and nurse practitioners know how to do PrEP, and will do it. More are learning. We're teaching more and more people. It's actually pretty easy to do. I tell people, the physicians who are not so sure about it, listen, it's just about like prescribing birth control pills. You need to know some things, but it's not complicated. It's not like trying to treat a patient with, serious disease. And so it's really not very hard to do. It's not real. A lot of people don't know how to do it, haven't been trained in it, but it's kind of gaining momentum. So there are a lot of people out there learning to do it, and a lot of patients looking for people that can do that.
Tell us a little bit about HIV testing. Who should be tested? How often is a person tested? And what do they need to know about testing?
So the tests are pretty simple. There's a variety of methods. You can get blood drawn for a test. You can get a finger stick test. There's an oral saliva swab test. Actually, you can buy those in pharmacies now if you want to do your own test at home. It is well, the CDC recommends that everyone have one lifetime.
And what types of problems would you have if you're not tested and you start to show signs? What would be some of the early symptoms or signs of HIV?
Well, let me just go back to the frequency of testing. One lifetime for everybody, but if you get a new partner, sexual partner, IV drugs, things like that, you should be tested. Just depends on your patterns more
and what
often.
types? Okay, and then what types of signs or symptoms would you have that would say, "Gee, I should be tested at this point"?
Well, for a lot of people, they won't have a lot of symptoms early on. When people are first infected, they may, a few weeks after they get infected, have what they think is the flu, worst flu they ever had, but they get over it, and then things back to normal until, it could be varies. It could be a year, it could be many years. They don't feel good. Usually first they're more tired, they're not feeling good, then they notice, I just get colds more often, and then they last longer. And then as things progress, if they haven't gotten diagnosed by that time, they get sicker and sicker, they get more pneumonias, and then when they get more advanced, they start getting unusual infections that people with a normal immune system don't get. But they end up, sometimes people aren't diagnosed till they're really sick and in the hospital.
And usually these would be people from risk groups that you've mentioned, people who are using IV drugs.
Well, it could be they used IV drugs, though, 10 years ago. So they won't really realize, well, I never got tested, and they're not even thinking that's in the scope of things.
Well,
but yes, it'll be either they were exposed sexually, or IV drug use are the most common.
Then let's switch gears and talk a little bit about hepatitis C, because hepatitis C affects more people in the population than HIV. Tell us a little bit about that.
So in the U.S. right now, there's probably about 1.2 million people with HIV. There's probably more like 2.7 million people with hepatitis C.
And how many of those people already know that they have it? How many have already been tested?
About 50% probably.
So there's another 50% of the population
who don't know they have it. With hepatitis C, people usually don't have much symptoms at all when they're infected, and they may not have any symptoms for 20 to 30 years.
And who's at greatest risk?
So the greatest risk are people who had a blood transfusion or an organ transplant before 1992. The CDC current recommendation is that anybody born between 1945 and 1965 get tested once. Intravenous injection drug use is another risk factor, and it only takes one time. So a lot of people don't even remember that one time they tried something, but they could have gotten it then.
And once you're tested, what is the treatment plan for hepatitis C?
Well, the treatment has evolved a lot. There's so many people with it, and the treatments are very expensive. They used to be a lot harder. The options were almost more kind of like taking chemo. They were just harder for people to get through the treatments.
And do we have newer drugs now?
We have newer drugs. They're much easier. They're very expensive, and so still we don't necessarily treat everyone just because it's hard to get those medications and get them approved, et cetera. But for sure, people who are starting to show any kind of evidence of liver disease, which is what happens, hepatitis C.
And what's the cure rate with medication?
Over 90% with the current
Which
meds.
is wonderful news.
Yes.
Yeah, so it's key to get tested, to get on a medication, and then to be able to clear the virus.
And and often we can clear it in 12 weeks, sometimes 24 weeks, depends on the type. There's several different types, and it depends on if you already have liver disease, but yes, you can get it cleared, and that's great. Now, you can get it again, so you still have to don't use drugs,
Sure.
basically.
Thank you so much. This has been extremely informational about HIV and hepatitis C. Dr. Loretta Stenzel. After the break, I'll be talking to Dr. Cheryl Thompson and Natasha Riley about cancer screenings and preventive care at VCC.
So they say it's a man's world? Well, I don't see anybody's name on it. While they were out doing their thing, we slowly changed all that. We changed all that. Today, women can do anything men can do. And there's one thing we're even better at.
Welcome back to this segment. My guests are Dr. Cheryl Thompson, family medicine physician at VCC, and Natasha Riley, breast health services manager at Vista Community Clinic. Welcome to both of you.
Thank you so much for having us.
Yes. Dr. Thompson, I'd like to start with you because we're talking now about cancer screenings and prevention. Why is screening and early detection such a key for preventing, on the one hand, but also to treating cancer when it's diagnosed?
Well, what comes to my mind, Vicki, is the story of a patient that came to me with shoulder pain, something that was unrelated to some of the screenings that we offer, but because he was 58 and at age 50 we want to start screening for colon cancer, I brought it up to him and he agreed to do the colon cancer screening test.
Is that done at the clinic?
We initiate the process. The patient goes home and does the stool test at home, and based on those results that come back to me electronically, we advise repeating it again in a year or going for further testing. So in this one man's case, his test had come back not normal. So he went for a colonoscopy with a specialist, and that specialist was able to find a cancer, and it was early, stage 1. He removed it. The patient went on for further treatment, and on December 31st of 2015, he had his last chemotherapy treatment and came in to see me and told me he was cancer-free. He told me, "Dr. Thompson, you saved my life." And that was one of those moments where I felt this is the work that I want to be doing, both in offering these screening processes to the patients and getting everything streamlined at Vista Community Clinic so that we can offer these routinely, just like that. So thanks to this man's shoulder pain, we were able to find and get rid of this colon cancer.
And what did you do for the shoulder pain?
He's now looking towards potentially getting surgery to fix it, but we had to
So
get
it was
this colon
that
cancer
visit
taken care of.
that
Yes.
gave you the opportunity to check on some other things. It's a wonderful example of being able to identify a problem and treat it when it's most treatable.
Right. So we're really trying to pick up when patients are due for things, even if they come to us for something else, that they haven't had their mammogram and they should have had it. And those tests.
What other screenings, besides the mammogram and the colon cancer test, what other screenings are you recommending?
I'm doing and offering patients appointments for Pap tests when they're not up to date. At age 21, that's recommended up until the point at which the doctor and the patient decide to stop, or age 65. The other cancer screenings are recommended by the U.S. Preventive Services Task Force, and if we don't do them at the clinic, then we refer the patients out, one of them with lung cancer, and one of the top 3 cancers that cause deaths in the U.S., and CT scan is recommended for that. It's imaging of the chest. That's something that we can refer patients for. We offer anal cancer screening. This is specific to our HIV patients that we have a number of at Vista Community Clinic.
So is that because they're at greater risk?
Yes, yes, age 30 that usually starts. And patients who've had a Pap test, that's cervical cancer screening, that showed the virus that can cause cancer in the cervix, should also be aware that they really need to get their colon cancer screening tests it's timely, because that same virus can cause anal, rectal, colon cancers.
Okay. Natasha, I know that you have a special project that you're working with in the community, identifying low-income women who are 40 years and older for breast cancer screening. Can you tell us something about that?
Well, sure. Our focus is on getting women 40 and over, as you say, to get breast cancer screening. And our outreach efforts, one of the major success of our program is that we understand the community and we meet women where they are. So we go out in a community, we go out to local community centers. We provide outreach and education about breast cancer and breast cancer screening to women at local churches, community organizations. We do group presentations. We also participate in local cultural events and health fairs and things like that. We go to supermarkets and provide outreach and education. We also send birthday cards to women in our system when they turn 40. We send them a birthday card, first of all saying happy birthday. Then we provide breast cancer education and letting them know about our screening services.
And how receptive has the community been to these? Are you getting a lot of women coming in for screenings at Vista Community Clinic?
Yes, we have a regular, we have lots of women who do come in on a regular basis for screening. Obviously, there's always more. There's still women that are not being reached. But yes, we screen hundreds of women a month for breast cancer.
And what about detection? How much cancer are you detecting in these groups as a result of your outreach efforts?
As a result of our outreach efforts, we have an average of about 30 cancers, perhaps 25 to 30 that are diagnosed each year that we're able to get into treatment. And the goal is to get women into treatment within 60 days of being diagnosed so that they can start.
Okay, Dr. Thompson, you would be involved once the patient is diagnosed. So tell us a little bit about the services that Vista Community Clinic offers for cancer patients.
Well, I connect them with Natasha's group right away when they're able to meet and provide the support groups. You'd be able to talk a little bit more. For the diagnosis, the steps as far as treatment, our referrals department becomes involved when I ask for the oncology, the surgeon to evaluate the patient.
And what we try to do, when a patient is diagnosed with breast cancer, when they come in to meet with a provider to get their diagnosis, we try to meet with them on that same day.
So that would be the physician that's going to follow their case?
That would be the physician, exactly. Then we would meet with them, with the patient right after they meet with their provider, right after they've gotten their diagnosis. So then we provide them with information we give them information about the treatment that they may be going through or that their treatment choices that they're going to have to make. We give them a list of questions to ask their doctors. We provide them with information to help them talk about their diagnosis with their family members. And we also give them information about resources that's within the clinic and the community, transportation, for instance, when they're going through treatment services, and then if they need assistance with things like child care or with getting food or housing, we provide them with information on those.
So the clinic is going way beyond just medical care to ensure that people are brought in, have screenings, and are able to receive care. And what about lifestyle habits? Is there a lot of emphasis on changing lifestyle habits for cancer prevention?
We discuss the importance of weight loss and weight control, of stopping smoking, if that's something that the patient's dealing with, support with that with our counselors as well. Eating whole foods rather than processed foods, and getting connected with food services or a nutritionist. And exercise, it protects from breast cancer. It's one of the great ways we can promote that.
So this is actually enabling the patient to take charge of their own health
Yes.
and to change their habits in order to ensure that they can prevent some of these diseases. Thank you for being with us, Dr. Deborah Thompson and Natasha Riley. And this ends our show on VCC's Health Education and Screening Programs. Thank you for being with us.
Community Health Matters was made possible by a grant from the Tri-City Healthcare District Board of Directors Community Healthcare Alliance Committee.